but one of the more rewarding in terms of treating patients with severe alcohol use disorder. Today, I'd like to talk about what I consider alcohol use disorder cirrhosis, a new paradigm shift in a clinical approach. I tell you, my interest in alcohol use disorder stems from my long-standing career in hospital medicine, where I frequently encountered the most severe cases of alcohol use disorder and associated advanced alcohol liver disease. And I now have framed as a philosophy my care of patients with alcohol use disorder and associated advanced liver disease as this unifying concept called AUD cirrhosis, which I view as a new paradigm to change how we not only approach this dual pathology of disease, but also how we diagnose, engage, and treat patients with AUD cirrhosis. Briefly, my objectives today, and everything is brief given that I was given 25 minutes. Oh, hi, Dr. Keto. Shout out to fellows here too. I see them past and former, yeah, and current, nice. Brief objectives here: recognize the epidemiology and neurobiology of alcohol use disorder, review current trends of alcohol-related morbidity and mortality. And I'm not going to go over the decades of data, but I'm going to focus more on the significant impact of the pandemic on what I'm talking about. And then try to briefly describe and understand the dual pathology of alcohol use disorder and alcohol-associated advanced liver disease, and then talk about the benefits of pharmacotherapy in patients with AUD cirrhosis, specifically sharing with you the results of recent emergent population-based studies that support this concept of AUD cirrhosis and how we need to change how we actually engage these patients, treat these patients, and follow these patients across the continuum of their disease. Most of you already know this. Alcohol use disorders are the most prevalent substance use disorders in the United States. When you follow NDUS survey, which is done every year from 2017 to 2021, you can actually see the increase in alcohol use disorders diagnosed. Before the pandemic, the diagnosis was based on DSM-4 criteria, and starting in 2020, criteria was changed to DSM-5, which demonstrates this significant increase from 2019 to 2020. And this is also in the context of the pandemic, where the surveyors couldn't do what they typically do in terms of surveying individuals, but had to rely to more internet and telephone-based surveys. When you look at alcohol use disorder in this country, in 2021, close to 29 million adults in this country met DSM-5 criteria for alcohol use disorder. And as we see in most of the substance use disorders we study, predominantly white, predominantly male. When we talk about the DSM-5 AUD severity, the majority of individuals in this country meet DSM-5 criteria for a mild disorder, but close to 42% of individuals in this country actually meet moderate to severe diagnosis of alcohol use disorder. And unfortunately, those who do meet moderate to severe alcohol use disorder criteria, less than 1% in 2021 received any pharmacotherapy for their disease. Ever since I trained as a fellow and practiced on faculty and as staff, I consider alcohol use disorders, unlike other substance use disorders, as primarily a neurodevelopmental disorder. And when we talk about the consequences of alcohol use during brain development, that vulnerable age from 12 to 25, when the brain is maturing, and alcohol is exceedingly toxic to not only brain development, but brain maturation, it also lends itself to really thinking out how we need to identify unhealthy alcohol use at an earlier age. In 2021, close to 900 adolescents met DSM-5 criteria for AUD, and more than 600,000 of those adolescents were women or females, which has resulted, or is the end result of a long-standing closing of the gender gap between men and women. And now, for the first time since we've studied alcohol use disorder prevalence, we start seeing in this particular age group as they get older, we start seeing more females with alcohol use disorder than males. The impact on females will be a common theme throughout my talk. Adolescents who drink before age 15 are 5 times more likely to develop alcohol problems as an adult. And when we talk about individuals who are diagnosed with alcohol use disorder over their lifetimes, those who drank before the age of 21, and those 2/3, half of those adolescents or young adults met criteria for an alcohol use disorder, had dependence before age 21, and 2/3 had evidence of alcohol dependence before the age of 25. I find this study particularly interesting to really reinforce this concept of alcohol use disorder as a neurodevelopmental disorder. This is a Swedish population study. I love the European nations that have single system healthcare systems where they have national registries where, oh, thank you. Where these countries with single system healthcare actually have the ability, because of registries, to longitudinally follow their citizens. And so this Swedish population study looked at close to 43,000 young men, late 1960s, who were conscripted or participated in mandatory military involvement or service, and followed them longitudinally over 30 years. And what they did at baseline in terms of a lot of other healthcare assessments, they actually documented how much they were drinking in terms of grams. And so what they found was, over the course of follow-up, when they followed these individuals, those who drank heavily, unhealthy alcohol use, 31 to 40 grams per day, had an HR or hazard ratio or a likelihood of developing alcohol-associated liver disease at 2 to 3.2 fold. Those who drank over 60 grams of alcohol at baseline had a HR of 3.66 of developing alcohol liver disease, and even greater than 2 standard drinks per day, the incidence of advanced alcohol liver disease was close to 3%. So what's the message here? In a country such as ours, where a significant amount of Americans drink alcohol, a more significant amount have alcohol use disorder, the earlier we discuss unhealthy alcohol use with our patients, our clients, our family members, the more we're going to prevent the development of alcohol-associated liver disease. And it reinforces what I've been saying. Alcohol use disorder is a young person's disease. It often takes 10 to 15 years before individuals seek treatment, which gives the false impression that alcohol use disorder only occurs in older adults. And that's truly not the case. When we talk about alcohol use disorders across lifetime, on the right, it's a graph of kind of lifetime AUD prevalence based on sex, race, ethnicity, age, and then broken down per severity. The patient in front of you, the client in front of you, over a course of a lifetime, close to 68 million adults will have a DSM-5 lifetime alcohol use disorder. Close to 10 million of those will meet criteria for a severe alcohol use disorder. Close to 33 million will have a past year DSM-5 alcohol use disorder, with 1.1 million of those having met criteria for a severe alcohol use disorder. And what's more concerning is more than 1 in 5 Native Americans will have a severe alcohol use disorder during their lifetime. 1 in 6 adults in the age group of 18 to 29 and adults 30 to 44 will have a severe alcohol use disorder during their lifetime. And the mean age of a severe alcohol use disorder in terms of onset is 23 years, with a 3-year lag before that individual actually participates in initial treatment. Briefly, I can want to review the current trends of alcohol-related morbidity and mortality. I want to talk about the last decade, but I can tell you this applies to the past several decades. Over the past decade, past year high risk alcohol use has increased close to 30%, more so across all age the demographics, but more so in women, more so in Blacks, and more so in older adults. Past year, DSM-4 alcohol use disorders have increased by nearly 50% over the past decade. Again, more so in women and Blacks, older adults. Specifically, that's 75% in older women. Lifetime DSM-4 alcohol use disorders have increased by nearly 44%. And what we have seen recently is that when we talk about healthcare utilization, female outcomes have started to surpass male outcomes. In terms of alcohol-associated liver disease hospital discharges, they're greater in young women, greater in women overall. Alcohol-associated hepatitis diagnosis, AH, is greater in women, and deaths and mortality are starting to be greater in women, more so than men. And unfortunately, in this country, despite the legality of alcohol, excessive alcohol use contributes to close to 5% of all deaths in this country. The one thing we do know is if we treat patients with alcohol use disorder, increasing the treatment up to 40% of individuals with alcohol use disorder would reduce this alcohol-attributed mortality by up to 13%. During the course of the pandemic, alcohol-related ED visits and alcohol-associated admissions increased during the pandemic. When we look at ED visits, we're looking at 2021 data from Dawn Network. Alcohol was involved in 40% of all drug-related ED visits, nearly 3 times that of opioid-related visits. And when we look at specific data in terms of healthcare systems, but really are reflected across this nation, alcohol-associated hepatitis admissions increased during the first months by 50% during the pandemic, and as the pandemic progressed during that first year, it increased by 2/3. When we talk about healthcare utilization, age liver transplants exceeded forecasts during the pandemic. In this particular time frame, new waiting list registrations exceeded forecasted values by 60%. So we know at a baseline before the pandemic, there was a certain number of individuals who actually were waitlisted for AH, alcohol-associated hepatitis. That forecast increased by 60% during the pandemic. Actual liver transplants in terms of base comparison to baseline transplanted for alcohol-associated liver, that forecast exceeded 62%. And this was in the context where, if you could see this particular slide here, where there was record monthly retail alcohol sales during the pandemic. And there was an obvious temporal association and a positive correlation with increase in alcohol use and alcohol-associated liver transplants. And more remarkably, there was no change for alcohol-associated cirrhosis or non-alcohol-associated liver disease transplants. This was an effect predominantly focused and impacting individuals who increased their alcohol use, resulted in severe alcohol associated hepatitis with an increase in early liver transplantation. Alcohol-associated liver transplants increased close to 270% during the pandemic. From this time period, June 2020 to February 2021, AH liver transplant wait list increased by 325%. There was 13 more liver transplants per month during the pandemic because of alcohol-associated hepatitis. These patients are young. We see it all the time in the hospital. The median age of 41. On our consult service, we see individuals in their late 20s, early 30s who are needing liver transplant evaluation because of severe alcohol-associated hepatitis. And there's no difference between these pre-pandemic and pandemic cohorts, really signifying that increased alcohol use during the pandemic was the sole responsible factor for this high utilization of transplants. Alcohol-related deaths increased by 26% during the pandemic. And it increased for all age groups, more specifically 40% for younger adults, 35 to 40, 37% increase for adults aged 25 to 34. There was no gender difference in terms of these increases. Alcohol-associated liver disease deaths increased by 22%. And then alcohol-related mental and behavioral deaths increased by 35%. And this outpaced all-cause mortality, which was 17%. And as we know, fentanyl and alcohol-associated overdose during the pandemic increased by close to 60%. And you can see where baseline here before the pandemic, there was slight, slow increase in the use of, in terms of alcohol-related deaths. But when you look at the yellow, it exploded during the pandemic and continues to be at an elevated level compared to historical baselines. Briefly, I want to talk about and hopefully have everyone have an understanding of this dual pathology of alcohol use disorder and alcohol-associated advanced liver disease. When we talk about alcohol-associated liver disease, it's a spectrum of disease in which continued significant alcohol use can cause progression from fatty changes to the liver to inflammation, fibrosis, and eventually cirrhosis. When you look at the blue, those are histopathological changes where we can't detect this on physical exam. And this is why alcohol-associated liver disease is such a very challenging disease to care for. Patients aren't presenting until they actually have disease or are symptomatic, but they probably have been struggling with the disease for several years. When we talk about the red box, those are the things we actually on clinical exam and laboratory findings can diagnose. And when the patient is actually presenting with that first episode of alcohol-associated hepatitis, at that point, we're talking about acute or chronic liver injury. And at this point, the patient is starting to meet those definitions for advanced alcohol liver disease. Talk about redefining alcohol use disorder and advanced alcohol liver disease in this population. And this is where I frame it as alcohol AUD cirrhosis. This concept of dual pathology. When we're talking about the advanced alcohol liver disease, we're talking about the direct liver complications. When we're talking about AUD, we're talking about the root cause of that liver disease. And more importantly, we're talking about a different shift in how we need to care for these patients, where optimal care involves addressing the biopsychosocial, cultural factors of alcohol use disorder and the medical and psychological aspects of advanced alcohol liver disease. I could always have to put this point at any talk I give because I am a hospitalist at heart. Hospitalizations are missed opportunities to discuss and enact life-changing interventions. And we pride ourselves on our particular service in the hospital, having the opportunity to engage individuals with substance use disorder. AUD cirrhosis is a major healthcare issue. Alcohol cirrhosis hospitalizations have significantly increased over the past 20 years. The mean age has increased, and that's likely secondary to improved medical care. But patients are sicker. When we look at the Charlson comorbidity index, that has increased to nearly 80%. Hospital costs have increased by close to twofold. And even though mortality is significantly decreased from 12.8 to 4.7%, Black patients are 15% more likely to die. And those patients who have CCI scores greater than 3 are close to 2 times more likely to die. Over the past decade, AUD-related transplants have increased 126%. You can see here by the purple line, which represents alcohol and liver disease. You can see where it's exponentially different from the other causes of reasons for having a related transplant. In 2021, alcohol-associated liver disease was responsible for 40% of all transplants. That was the #1 etiology. It was 4th in 2011. And in 2023, liver transplants continue to increase at record levels. As of September, there's already been 811 more liver transplants in this country compared to 2022. And early liver transplantation secondary to severe alcohol-associated hepatitis is the likely driver. Talk about the benefits of pharmacotherapy for AUD cirrhosis. I think we're all aware that AUD pharmacotherapy is effective. not only for AUD, but for AUD cirrhosis, but underutilized. When we talk about looking at emerging population level outcomes in AUD cirrhosis, unhealthy alcohol use is associated with a 13% higher risk of mortality, an 18% increased incidence of decompensation, and a 72% lower likelihood of liver transplantation. So it's so important for us to not only address our individuals with alcohol use disorder, but our individuals with AUD cirrhosis, to really focus on and engage them in not only, hopefully, achieving abstinence, but if not the case, applying harm reduction and hopefully resulting in drinking less. And again, focusing on the disparities between men and women. Heavy alcohol use is associated with alcohol-associated cirrhosis. It causes that clinical entity close to 13 times more in women compared to 4 times in men. When we look at large population databases in terms of insured patients, FDA-approved pharmacotherapy rates for AUD cirrhosis, i.e. in this particular population study that included 27 US healthcare systems, those individuals who had AUD cirrhosis were lower and less likely to receive pharmacotherapy compared to individuals with just AUD. Those individuals with AUD cirrhosis were treated with acamprosate 1.47% of the time, and with naltrexone less than 2% of the time. This particular fact here reflects work done on a large commercial insurance database where they looked at close to 70,000 individuals and found that within 1 year of index of AUD cirrhosis diagnosis, only 10% of those individuals received a face-to-face mental health or substance use visit, and less than 1% actually received an FDA-approved medication within 1 year of the index diagnosis. And women were 11% less likely compared to men to receive MAUD that was FDA approved. Those who actually did receive FDA-approved MAUD had an 11% decrease, a 35% decrease in risk of decompensation at 1 year. And even those who received a visit in terms of mental health or substance use care had 11% decrease in decompensation. So medications are important. Actually, psychotherapy is important. Both modalities have been shown to decrease the incidence of newly diagnosed hepatic decompensation in individuals with AUD cirrhosis. What's the impact of AUD treatment on clinical outcomes in ALD patients? This is another study. This is a retrospective VA study looking at mostly 35,000, mostly white, older males. But those who received an AUD intervention actually had 37% less incident decompensation, 21% less 180-day all-cause mortality, and 13% less long-term all-cause mortality. 14% of these AUD cirrhosis patients had treatment. The majority of them received psychotherapy. 3% of them received FDA MAUD, and 9% received both. Whites were more likely to receive MAUD in this population, and Blacks were more likely to receive behavioral treatment. Why does that matter? Pharmacotherapy was associated with a 79% fewer deaths compared to behavioral treatment. And so not only when we're talking about disparities between racial and ethnic groups, we have to really apply a standard of care when we're talking about treating patients with AUD cirrhosis. All of them should be considered for MAUD. MAUD improves survival in AUD cirrhosis. Another VA study, this time looking at close to 91 patients with AUD who actually had high-risk hazardous drinking and newly diagnosed AUD cirrhosis. Retrospective propensity match study. MAUD in terms of naltrexone or acamprosate in the first year after an AC diagnosis was associated with a 20% decrease in mortality, and longer duration of MAUD was associated with a 27% decrease in mortality. You can see the Kaplan-Meier curves here as they separate out the curve on the bottom actually shows you the difference between no MAUD and the MAUD lasting less than 3 months and greater than 3 months. Benefits of working in Mass General is we have dedicated specialists, including hepatologists who are very interested in not only treating patients with alcohol use disorder, but also very, very focused in preventing the development of alcohol-associated liver disease. This is from the MGH Alcohol Liver Clinic. It's an analysis of the MGB Biobank, which is a research initiative, close to 130,000 patients that they looked at from 2010 to 2017. And they looked at individuals who were treated for alcohol use disorder and those who had ALD compared to those who didn't. It was close to 1,100 patients who had ALD, close to 350 were treated, 786 were not treated. When we looked at the impact, what we see is those individuals who are MAUD, and they looked at 6 different drugs, those who are MAUD throughout this population cohort analysis had a decreased incidence of the development of ALD. Unfortunately, those individuals didn't start MAUD till a mean 1.65 years after their AUD diagnosis. So the clinical benefits are probably larger than shown in the study. But what was really important was that each year the individuals received treatment that was associated with 3% less likelihood of developing ALD. The drivers of this 63% decrease in the incidence of ALD was mostly gabapentin, topiramate. And what I really want to highlight, which has changed my practice, is acamprosate was actually associated with an increase in ALD, not a decrease. Thank you, Dr. Beer. Also, these medications were demonstrated a decreased incidence in the initial episode of hepatic decompensation. Again, 65% decrease overall, driven by naltrexone and gabapentin. Again, each year that treatment was received was associated with a 7% decrease in hepatic decompensation. When we talk about MOUD and the development of cirrhosis over 10 years, there was 59% less hepatic decompensation with MOUD after a cirrhosis diagnosis. The mean time to hepatic decompensating event was significantly longer with MOUD, 6.3 versus 2 years. Again, this delay in treatment mean 3.8 years before these individuals with AUD cirrhosis received treatment. But those who did had 47% more days of hepatic compensation with pharmacotherapy. Now, naltrexone and gabapentin significantly reduced the development of advanced alcohol-associated liver disease, the development of hepatic decompensation, pre- and post-cirrhosis diagnosis, and more importantly, pharmacotherapy significantly reduces and delays the incidence of acute or chronic advanced alcohol liver disease and results in more days of compensated liver disease, all of which are life-saving and altering. In terms of summaries, AUD is the most prevalent substance use disorder in the United States. Close to 29 million adults in 2021 had this disease. As I said before, adolescent females are starting to show that gender gap has essentially closed between men and women with alcohol use disorder. Unfortunately, only 2.9% of individuals felt they needed treatment, and those who felt they needed treatment, only 0.9% received evidence-based MOUD. Increased alcohol use is driving healthcare utilization pre-pandemic and during the pandemic. Long-term impact is unclear. AUD cirrhosis represents a due pathology with significant morbidity and mortality. ALD morbidity and mortality is increasing pre-pandemic, significantly so during the pandemic. I would say AUD cirrhosis is an emerging public health crisis. Population studies have predicted that ALD related deaths are only projected to increase 8.2 per 100,000 person years currently to close to 15.2 in 2040. Unfortunately, there's a dearth of clinical trials studying pharmacotherapy efficacy and safety in AUD cirrhosis. Population studies demonstrate pharmacotherapy in AUD cirrhosis is unutilized but associated with significant improved patient outcomes, including the incidence of advanced ALD, decompensated disease, ED, and hospital utilization. And as I showed in several of these population studies, it does impact mortality. MGH population studies suggest naltrexone and gabapentin are significantly associated with improved advanced alcohol liver disease outcomes. And more importantly, pharmacotherapy in patients with AUD cirrhosis is life-preserving, more effective than behavioral treatments. And my final thought in how I practice is there needs to be an urgency in recognition, diagnosis, and treatment of AUD cirrhosis. Thank you.